Good afternoon. Thank you to the scientific committee and Professor Vidanglu for inviting me again to present, to discuss use of coated flow diverter P64 MWHPC and P48 the MWHPC in the treatment of intracranial aneurysm. Thank you. Okay. So here are my disclosure. I am consultant for Phenox company. Surface modified flow diverters, you know, it's a very important topic now in the field of INR. You know, surface modification has several goals according to what was presented by Matthias Gavlitza recently. One goal can be to improve navigability of the flow diverter. It is what is expected with, for example, Fredix from Microvention. We will have a presentation after mine. Another goal can be to reduce platelet aggregation and thromboembolic events. It is the case with Shield Medtronic, and it is also the case with HPC from Wallaby Phenox. And finally, another goal of surface modification can be to improve endothelialization, and it is the case, for example, for CD31 from BALT. Just to briefly describe Phenox hydrophilic polymer coating, HPC, it's a glycocalyx-like polymer that you place at the surface of biomaterials in order, you know, glycocalyx, we have it physiologically in the human brain. You know, it is preventing platelet aggregation on the arterial wall. So HPC is a glycocalyx-like and is also preventing platelet aggregation, as it was demonstrated in several labs evaluation and also animal evaluation. So just to show you briefly what is P48 MWHPC and P64 MWHPC, the most important features. So you potentially increase the safety for the patient due to the coating. The delivery, both P48 and P64 can be delivered through the 21 microcatheter. You may have, there is a very specific features of this device, which is movable wire, which means that the wire you have inside the flow diverter, you can move it independently from the flow diverter. It means that you can push it singularly if you need more support. You can retrieve it if there is some danger for a small vessel distally. So it's a very interesting feature of the device. It is fully visible due to the fact that it's DFT wires with platinum core. It is easily detachable, and finally, it has a wide range of sizes that permits to treat several kind of aneurysm. So the area of application, P64 is dedicated to the biggest vessel, ICA basilar artery, and P48 is dedicated to more distal vessel, but there is an overlap between both. It is more depending, in fact, on the diameter of the vessel than on the location of the aneurysm. So I will not go through this, but the most important feature is that it can be used through the 21 microcatheter. I will show you briefly some cases we have treated in my department. It's a ruptured ICA treated in 2015 with a Fred 4.4 5 by 15. And you know, in 2020, we see that there is an aneurysm remnant. So we decided to place another flow diverter in the first one. We do a procedure 2 in 2020 by using a P64 MW HPC 5 by 18. So you see, you have, I don't know if I show it. I will come back. Yeah. So you see here, you have the thread device, and you have inside P64 MW HPC. And finally, we had a follow-up with a 14 months control angiogram showing the complete occlusion of the aneurysm. Another example here, unruptured IC aneurysm in a female 67 years old, treated by placement of P64 MW HPC. It is a cone-beam CT, which is, as mentioned before by Dr. Tomasello, very important for evaluating the precise location and the application of the device against the aneurysm wall. So you see here the device fully deployed, and it is a 12 months control angiogram showing complete aneurysm occlusion. Here, another example, it's a ruptured small MCA aneurysm. You see the small aneurysm here, you see the bleeding here, and you see we were able to place P48 MW HPC 3 by 12, sorry, and at 12 months the control angiogram was showing complete aneurysm occlusion. Finally, it's ruptured decom treated in 2010 with coils. At the end of the initial procedure, you see that we had a complete aneurysm occlusion, but in 2019, we had a recanalization of the aneurysm, so we do an additional treatment with coils and placement of a P48 MW HPC, and it's 12 months control angiogram showing complete aneurysm occlusion. We always do MRI 24 hours or 48 hours after the treatment, mostly to check if we have some spots on DWI, and we have some here. I show that because it's a part of the cutting study. So preliminary results with HPC flow diverters. We were publishing with Americare a preliminary series of P40 MW HPC used with dual antiplatelet treatment. And you see that treatment feasibility was very high, 100%. Intraoperative complication were relatively rare, no intraoperative rupture. Thromboembolic complication in 2 cases, 7% with no clinical worsening in both cases. There was no morbid mortality. On anatomical results at more or less 6 months were complete occlusion in 87% of aneurysm and neck remnant in 9% of aneurysm. So very interesting results. There is also the series of Borum published by Victoria Elstern and the team of Hansenkes, 100 patients, 128 aneurysm treated with simple antiplatelet treatment with prasugrel. There was a technical success in 100%. There were good anatomical results at 4 months and 9 months. You see that at 9 months we have very good complete or near complete occlusion in 88% of cases. There was no mortality and no morbidity. There were some intraprocedural complications, but no thrombotic or hemorrhagic complications. There were more technical problems, flow diverter foreshortening, flow diverter collapses, and there was one ICA dissection. There were also some post-procedural complications in 7 patients, and delayed complication after 30 days in 1 patient. So now cutting study is precisely evaluating the feasibility of treatment with this surface modified flow diverter under single antiplatelet treatment. So what is cutting study? It's a European multicenter prospective randomized controlled trial which will compare aneurysm treatment with bare P64 MW under dual antiplatelet treatment, which is current treatment we are doing in all centers, to aneurysm treatment with coated P64 MW HPC under single antiplatelet treatment. So the design to assess safety and efficacy, so we have a lot of criteria. I will show you the criteria. Between bare flow diverter under single antiplatelet, under dual antiplatelet therapy compared to coated flow diverter with single antiplatelet treatment. So the primary hypothesis, the design of the study is an adaptative design. So the primary hypothesis is that there is non-inferiority of the treatment with a coated flow diverter and a single antiplatelet treatment compared to bare flow diverter and dual antiplatelet treatment. And maybe there will be, after an intermediate assessment, superiority design. So the primary endpoint, and it's something original in this study, is the number of diffusion-weighted imaging spots assessed within 48 hours after the index procedure. So with MRI indeed. On the secondary endpoints, there are a lot of secondary endpoints which will evaluate the safety and efficacy of the P64 MWHPC under SAPT up to 365 days post-procedure. So the goal is to include 200 patients, 100 per randomization arm, and 25 centers in 7 countries. So the first patient in was in Q3 2021 in France, and the last patient is expected in Q4 2023, and the final study report is expected Q2 2025. So the randomization is one-to-one. The patient can be randomized in the group of surface modified flow diverter with HPC under SAPT. SAPT can be prasugrel or ticagrelor, but not clopidogrel. There are roughly 30% resistant to clopidogrel, so the reason why clopidogrel is not part of the study. So the treatment is 6 months ticagrelor or prasugrel only, followed by 6 months aspirin. On the comparison arm is P64 MW, the bare version, under dual antiplatelet treatment, prasugrel or ticagrelor, on aspirin for 6 months, followed by aspirin for 6 months. So it is a steering committee made by me and Professor Cognard, Dr. Lamine in Birmingham, UK, and Professor Spell in France. We have a lot of independent expert groups to evaluate everything. So you have here the list of the physician part of the committee. So what is the current status of the study? The study started in most of the country. We are still waiting for ethics committee approval in Israel and Slovakia. As of now, we have included 75 patients. 75 patients are already randomized, and 71 were already treated. So in conclusion, surface modified flow diversion will potentially enlarge the indication for flow diversion. As of now, none of the surface modified flow diverter has been properly evaluated with a randomized controlled trial, including pipeline shield or Vantage, and Coating is the first multi-center RCT comparing a bare flow diverter under dual antiplatelet treatment to a coated flow diverter under single antiplatelet treatment. Thank you for your attention.